Welcome back to Open Med School. Today I'll be discussing a patient with septic shock. The interpretation of ABG in that patient and management. So this is the history of a 45-year-old man with a septic shock due to pneumonia and is in the ICU. As we know, sepsis can lead on to lactic acidosis, and what we expect is a metabolic acidosis. So let us see the ABG. The pH is 7.08. So pH is low, less than 0.7, 0.35. So patient has got acidemia. What's the primary reason? It is not the carbon dioxide, because the carbon dioxide is decreased here. We expect is 35 to 45. Bicarbonate, this is the value from the ABG. This is 9. So definitely low. So this means the acidosis is produced due to a metabolic reason, that is low, reduced bicarbonate. So it is a metabolic acidosis. In all metabolic acidosis, you have to calculate the anion gap, and anion gap is calculated by using the formula sodium minus chloride plus bicarbonate. So it is 24. So 140 minus 106 plus 10. So it becomes 24. So this patient has got a high anion gap metabolic acidosis. So our patient has got metabolic acidosis despite the fluid management and vasopressors, and the ICU team considers sodium bicarbonate therapy. Is this patient a genuine candidate? So let us look what are the indications for bicarbonate therapy. One, pH is dangerously low, that is less or equal to 7.1. Or patient has got a significant myocardial depression. Again you can give. Bicarbonate therapy is considered when severe metabolic acidosis, that is pH less than 7.1, bicarbonate less than 10, which threatens the cardiovascular function. So in severe metabolic acidosis, bicarbonate therapy can be given. This is a little controversial topic. I will repeat once more the indications. Severe metabolic acidosis, pH less than 7.1 or bicarbonate less than 10 milliequivalents per liter. Life-threatening hyperkalemia is another indication. Certain intoxications like tricyclic antidepressants, salicylates, phenobarbital poisoning also you can give. In renal tubular acidosis with the symptomatic acidosis. What we are discussing is the intravenous administration of bicarbonate. In chronic kidney disease, we are giving bicarbonate. That is a different condition. So when you are giving bicarbonate, you have to calculate the deficit and then infuse. So bicarbonate deficit is calculated by a formula 0.5 into weight in kilograms into desired bicarbonate minus the measured bicarbonate. Suppose the patient is elderly, you can use 0.4, and half the dose is infused initially. So suppose the patient is 70 kilograms, aim or the desired bicarbonate should be around 15. So the formula will be 0.5 into 70 into 15 minus 9. It will be around 210 milliequivalents. Given cautiously, half the dose in 4 to 6 hours. Suppose it is 210, you give around 100 or 110 ml. Few words about the bicarbonate ampule. What is available in our place is 8.4% soda bicarb in 50 ml ampules. 50 milliequivalents, that is 1 ml is equal to 1 milliequivalent. So that is an easy calculation. Remember, 1 ml of soda bicarb equals 1 milliequivalent. How to give? Bolus is given only rarely. 1 ampule, that is 50 milliequivalent, can be given over 5 minutes. This is usually given in patients with cardiac arrest, again controversial, tricyclic antidepressant, toxicity, hyperkalemia, again you can give. Infusion is the usual one in the protocol in the ICU. Take the required ml. Suppose it is 150 ml you are planning to give or 150 milliequivalent. You dilute in 500 ml of dextrose water. Don't use normal saline. Infuse over 4 to 6 hours. Recheck the ABG and electrolytes after every 2 to 4 hours. You check the sodium, potassium and chloride because you can produce hypernatremia, hypokalemia and hypocalcemia. Fluid overload is a important risk factor. Stop if the pH is going above 7.2 or 7.25. So don't try to achieve a normal pH. Your target is around 7 to 7.25. And bicarbonate target around 18. Don't go beyond that. So what are the cautions? As mentioned, avoid to large volume because this can produce paradoxical CNS acidosis because bicarbonate will be split into hydrogen ions and carbon dioxide. So it can produce paradoxical CNS acidosis. Avoid normal saline because it worsens hyperkalemic acidosis. Do not aim for normal pH, only partial correction is required. Hope is clear to you. So this is in summary. I have discussed the indications, how to calculate, few facts on the ampules, and how to monitor and how to administer. In the next session, I will be discussing the interpretation of ABG on a patient who has been given bicarbonate. Stay tuned. Thank you.